Very happy to be here with you today. Just to check, can you hear me?
Yes.
Good.
Yes, perfectly.
Wonderful. I'm on the other side of the Atlantic Ocean in the West Indies, and I'm just got out of bed. I just heard the last three talks, and wonderful. It's just wonderful to see how much Europe is moving forward, and the people involved in Enter are in many ways a lot further forward than many of the professional organizations. And that's wonderful to see. In other words, bravo, Enter, we are fantastic. I'm not joking, I'm being very serious here. Okay, perhaps just if you would allow me to react to the very last speech, the Copenhagen Maskina Center is just wonderful, and it's actually the conclusion of the speech that I'm about to give, which is towards the creation of real community mental health centers, real things where everyone is involved. There's one idea in terms of breaking down this terrible barrier between professionals and users of the system. One of the most important things we could start to do now, and I'm talking from the point of view of users and the point of view of the user organizations, let's start talking about the mental health of psychiatrists. Let's start talking about the mental health of mental health nurses. Let's start talking about the mental health of the professionals. In other words, we're not just going to talk about the mental health of sick people. We need to suddenly say that mental health concerns everybody and that they can be users too. The professionals also need to be able to talk about this. And it is, in fact, if they are not talking about it in their professional life, I think they're not doing a good job. That's the way we need to move our institutions. How can we say, what's a wonderful day for a mental health nurse? And what's a terrible day? What stops a mental health nurse from sleeping well? Is she more aggressive when she hasn't slept well? I'm looking at Moitza Jurek there, an obvious example of someone who becomes aggressive when she hasn't slept well. I'm joking, Moitza, forgive me. But extremely important to break down these barriers. It's not just sick people who have mental health problems. It's everyone has mental health and mental health problems. And mental health problems are not necessarily just negative. A mental health problem in the good old Greek sense of the word problem can be a mental health challenge. I want to learn how to sleep better. How can I do that? And can we all sit around the table and talk about that, please? All of the professionals and the users. And can the professionals talk about what helps them sleep better? I mean, is it one of the vodkas in Lithuania that makes them sleep well? Is that the solution? Or is it having had a wonderful day? Is it having had physical exercise? Is it eating well? What makes me, in other words, let's start talking about mental health for everyone as a key way of breaking the barrier between users and professionals. So that's just a little suggestion. Now, if I can go and share my screen and look for the presentation. I think it's this one. Share. Can you see it?
Yes, we can. Thank you.
Okay, great. So I'm just going to go through very generally through the recent history of mental health administration in Europe and to talk about the transition from hospital care to community care. and the fact of how that puts into question the traditional biomedical approach, and the fact that we very urgently need everywhere to prioritize also the social determinants of mental health. The solutions are not just biomedical, clearly. Now, it's obvious to everyone around the table, I think, but I'll just go through the history of this in the last 20 years. Okay, the size of the problem, we must have this information. It's an important argument for looking for money. If I can talk to the Copenhagen people, they're constantly asking us for money. This is a very important issue. EU population with a new mental health problem in the last 12 months. Okay, you see major depression, psychotic disorders, alcohol, panic disorder, phobias. Okay, this is from a study from 2005. 82 million people have a new mental health problem in the last 12 months in Europe. Okay, it's a major issue. It's an issue that has a significant impact on the whole of society. And it's a very obvious source of arguments to get funding to fund mental health projects. In Europe, 20% of all ill health and premature death is related to mental health. Suicide and self-inflicted injury, the image on the right, different age groups and different countries. Where is happening? Where are people committing suicide? Depression is the third leading cause of disability, and in Europe has the highest suicide rates in the world. It has actually the highest declared suicide rates in the world. In other places, they will hide this, but at least we have the advantage of being able to talk about it in Europe. Neuropsychiatric conditions, years lost to disability. In other words, years of functioning effectively in society lost to disability. Number one cause is depression. The number one cause, the number one problem, health problem of Europeans is depression. Number two problem is alcohol use. And this is including, I'm talking about ranking one and ranking two, number one and number two. It's talking about all health questions, not just mental health questions. Depression is the most important, in terms of years lost to disability, the most important problem, health problem in Europe. Alzheimer and other dementias comes in 7th position, schizophrenia in 11th, bipolar disorders 12th position. But constantly, I again put the stress on the importance of talking about about these frequent mental health problems, unipolar depressive disorders, alcohol use disorders, talking about those, talking about these problems in mental health professionals is also a significant way of changing our system so that everyone has the right to talk about their mental health and that we can all profit from hearing people talk about their mental health. And this includes professionals. More than 1 in 4 Europeans are confronted with a significant mental disorder during their lifetime. And these major conclusions of these studies 15 years ago led to significant political acts in the European Union. In terms of cost, healthcare costs, you see the 4 columns there. The one on the left is mental illness, then cancer, respiratory disease, AIDS, in billions of dollars. Mental health costs a fortune. Mental health problems costs a fortune, between 3 and 4% of the gross European GNP. Okay, and it's not just healthcare costs, it's productivity in employment. The depressed person doesn't work as well, doesn't do their job as well. Impact on families, on the people around, the people with the problem. Premature death, Okay, so the importance of these issues in Europe, just mental health is the major mental health problem and most expensive one in Europe. Let's start trying to talk about, use these arguments for getting our funding. Okay, and this is all stuff that we know. Mental disorders and poor mental health have large social and economic impact on societies. And I'm talking about this to underline the fact that in the old world, where people with mental health problems were put into asylums and removed from the societies, in this new world, we start seeing the interaction between mental health and social factors and the social determinants of health. Okay, so we'll just move on so that we can talk about it. The Mental Health Action Plan for Europe 2005. Okay, the aim was to develop, implement, and evaluate policies and legislation that will deliver mental health activities capable of improving the well-being of the whole population, preventing mental health problems, and enhancing the inclusion and functioning of people experiencing mental health problems. In other words, 2005, the whole European Union started concentrating on mental health. They started listening to what the economists were saying, what the health, the social health, sociological professionals were saying, that this is an enormous issue. It's costing us a fortune. It has an extreme impact on the whole European society. Let's start talking about it now. Okay, the action plan underlines the importance, and this is the essential thing of the speech that I'm giving, and also the last three interventions that we heard just before this, the importance of care in the community. And this transition, let's just look back historically on this transition, diminishing the role of traditional large-scale mental hospitals and promoting the development of community-based mental health services, including the integration of mental health services into primary health care. In other words, not just specialized mental health centers in the community, but mental health being part of primary care, with a series of major objectives that we in Enter have been talking about for the last 20 years. Recovery, the idea that yes, we can get better. Prevention, empowerment, and of course, social inclusion of people with mental health problems. Now, this major transition from the old system of hospitals to the new system of care in the community has critical implications for how we are supposed to care for people. We suddenly realized that the social factors, the community factors, have an enormous impact on the mental health, on everyone's mental health. This puts into question the old purely biomedical approach. Okay, clearly, the 2005 Mental Health Action Plan stated very clearly, we must close the asylums across Europe. And this is a quotation, "There is no place in the 21st century for inhumane and degrading treatment and care in large institutions. An increasing number of countries have closed many of their asylums and are now implementing effective community-based services." This is 2005. They were talking about many of the countries, but just having chaired Enter for many years, there are still many of these asylums that still exist. We still must keep fighting in this direction, closing these damned places. Rethinking our priorities. Okay, this sentence again is a quotation. With the development of community mental health programs, it has become increasingly evident that the 20th century traditional biomedical model of psychiatric care is no longer sufficient. Psychosocial, social, and economic issues at a local community level have a huge impact on people's mental health. In other words, if we're talking about caring for people's mental health, we need to look at where they're living, how they're working, how they're earning a living, all of these questions. Okay, the 2021-27 Action Plan, Europe, published at the end of last year, but developed in 2020. The European Parliament launched this EU Action Plan on mental health. And it's very carefully phrased so that it doesn't offend psychiatrists too much, okay? Demanding that equal attention be paid to the biomedical on the one hand and the psychosocial determinants on the other. In other words, they're saying they have equal value. We must work on both of these aspects equally. And emphasizing, again, this is a quotation, basic human rights at a community level. A whole new world is opening up for mental health professionals. Okay, but extremely important in very heavy countries like France, enormous countries with a very centralized decision system. The decisions are made right up at the top of in the ministries, at the national level, and not at local levels, or with great difficulty at local levels. And the whole problem in France, very slow ways of changing. And when it changes, it's a decision up the top that suddenly, for example, creates community mental health services all over the country without necessarily being integrated really into local communities. This is the essence of the future steps. In other words, how can we make sure that the mental health projects are community projects and not just national projects sent from above? The obvious things, and historically, you know all about this, we just look at it briefly again. Basic question, housing works, those famous projects in France, Chez Soi d'abord. Okay, in the 1990s, the non-governmental organization called Pathways to Housing in New York, the famous one, and working with people who had mental health and drug problems, typically, a model that rejects the old idea that the person has to be cured, to be clean, to access housing. In other words, we had to treat the person had to be non-psychotic, the person had to be non-alcoholic, to have cured that, to access housing. That model has to stop. And that model began being put into question at the end of the last century in these famous examples in New York. In other words, you don't have to be clean to access housing. Once you access housing, it's a major factor in you becoming clean, in you being able to handle your mental health problems, your addiction problems. And the second item there, rejecting the old continuum of care model. In other words, the person started in emergency shelters. They were stabilized, working with mental health professionals. They were moved into collective housing. And then maybe if they were lucky, they would find their own house, their own flat. Okay, based on the idea that you had to treat the causes of homelessness before providing housing. This whole theory put into question radically at the end of the last century, the beginning of this century in Europe, in many places, with housing first programs, putting the homeless person direct into their own home. And there, understanding that if having a place of one's own is a major factor in improving one's mental health, in feeling better, in being able to feel better, in being able to sleep better. All of these things, these simple social determinants that have extreme effects on people's mental health. A home of one's own. Initial results in America, 30% of chronic homeless people provided with housing in the space of 3 years, thanks to the Housing First type programs. A significant reduction. these people who had access to housing used emergency hospital services much less. If they were hospitalized, their length of stay in hospitals was reduced considerably, very significantly. And if they had serious drug problems, drug trafficking, and they were imprisoned, the length of their stay in prison was much less. It was much easier for them to leave the prison. They had their own home. They felt better. 70 to 80% of the people still in their housing 4 years later, after the initiation of these huge projects. And the health economists, underlining that this approach was significantly less costly than traditional approaches. In other words, keeping people in asylums costs a bloody fortune. Allowing people to have their own homes, financing their own homes, it costs significantly less. The people feel much better, are much better. They cost much less in terms of healthcare in general. Work, housing, work, free and equal access to appropriate care and accommodation is not enough. Work works. Having a job improves your mental health, improves your health in many levels. We contribute to society, we are useful, we feel useful. We earn our living. We are no longer just getting a government fund for a mentally ill person. We're earning our living. We contribute by our diversity. People understand the importance of developing systems that take into account mental health differences in the population. We have something to do. We have a reason to get out of bed every morning. I've got to go to work. We meet people. They meet us. We are part of things. We understand how the system works. And the system begins to understand how we work. The importance of all of these networks, and the conclusion, work works. It's work, having work improves your mental health and is effective in preventing mental health problems. And here we arrive where we were this afternoon before I started, local mental health councils. It's being even more radical than what we saw in the Copenhagen presentation, bringing together representatives of the users of the mental health system, families, healthcare professionals, social and cultural services, elected municipality members, insisting on the fact that within your local communities' health centers, you have also elected people. In other words, people who can take your issues to Parliament, who can take your issues to the local city councils and argue with everyone and start developing a culture of mental health at local community levels. In other words, we begin to evaluate mental health needs and adjusting responses to take into account these mental health needs at a local sector level, not at a hospital level, not at a government level, not at a regional level, at a local level, with people living with the problems and the community power base, using the resources available in the local communities. And that is just to add, and here is the example, the Danish example, free and equal access to appropriate care and accommodation is not enough. We need social linking mechanisms that help people keep in touch with society. And again, I underline that help society keep in touch with people. We need the society to be in there, in the clubs as well. Social and cultural activities are not just superficial amusements. They are essential for all of us. It is essential that we have fun building things together, creating together, seeing what someone else is creating something and showing what we have created to other people. These interactions are one of the most rich moments, one of the most rich things in our societies. In conclusion, yes, there are biomedical determinants of mental health. Yes, there are psychosocial determinants of mental health. Yes, we have won that battle. I hope. Let's keep fighting. We must take both into account if we want to change our mental health. Recovering from mental illness, preventing mental illness, promoting mental health. At all three of those levels, recovery, prevention, and promotion, we need to examine carefully the psychosocial determinants of mental health. And we need to have experts in the psychosocial areas working in our mental health community centers. Okay, merci. Thank you very much.